So what is
So, yeah, tips and our orals, just as we've done the last 2 days, we'll give them a 10-minute warning when they're 5 minutes in, 5 and 2, so that there's plenty of time for Q&A. And this generous spirit that we have started and continued this week, but I know will continue today. After the orals and the e-postings on YouTube, we will announce our local winner, our student who will be the best oral presentation of this week. Ready? Okay. She's ready. You got your. Welcome, Vanyan.
Good afternoon, everyone. My name is Nyakya. I'm a PhD student at the University of Wisconsin-Madison. I'm going to be talking today about usability testing, patient talk, and electronic patient-reported outcomes tool. I'm just going to be reporting the lessons that we have learned from usability testing and try to avoid all these technical things that we were dealing with during that time. So I have done this project along with Professor Schuning, Del Wilson, and Ford already, who's not with us today. So what is patient talk? Yesterday, Professor Schuning talked a little bit about this project. So it's an electronic tool that collects patients' reported outcomes from patients. And it was originally developed by investigators in LA, California to collect patient-reported outcomes from patients who do not speak English or who have literacy problems. Then in this project, it was later adapted to be implemented in pharmacy settings. So what it does, it actually allows patients to update their medication profile, report their medication-related concerns, and report their adherence to the medication that they have concerns about. And after they share this information in the app, the information is sent electronically to pharmacists, who will use this information to provide personalized counseling to patients and address all the concerns that were reported by patients. In here, you can see the list of PROs that is collected by patient talk. So we have medication regimen complexity index, a brief medication questionnaire for adherence, Merck estimator for adherence. Also, it collects satisfaction with the pharmacy services and pharmacists in general. And it has also measures for the social determinants of health. It's targeted for patients who have hypertension, diabetes, and high cholesterol. It can be collected, it can be used by patients or their caregivers. So this is a little bit complex about this app. And for the implementation side, it's planned to be implemented in 3 states. So in Indiana, and the PI there is Professor Martin Snyder. In Wisconsin, Professor Schuning is the PI there. And in Minnesota, the lead PI is Professor Schoenberg. So it's a very big project, an implementation study. And as you see, it has several phases. So it started by collecting information about various facilitators for implementation. After that, the app was adapted to make it suitable for pharmacy setting and make it specific for the PROs that we are looking for. And now I'm going to be talking about the usability testing because we need to make sure that the app is working well and there are no bugs, no issues before it's launched into pharmacies. The next step would be to pilot test it in pharmacy and scale it to a larger number of pharmacies in the future. So the study aims are to assess the usability and feasibility of patient talk, identify areas of improvement in the visual design and the language. And in order for us just to have a framework that would guide, our observation tool that we have used during the usability testing, we use the hierarchical model of usability factor. So this model posits that in order for any technology to be usable, in terms of effectiveness, efficiency, and achieve high satisfaction, you don't look at the higher level. We have to be assessing the lower level, which are the usability properties. So the properties can be divided into logical, graphical property, such as, so here we're talking about the observable feature of the technology, the scrolling, the navigation, the menu content, the menu structure, the colors, the design, all of these things. If we had issues in these things, we are not fulfilling the usability criteria, which would lead to problems with effectiveness, problems with satisfaction. So in the study, we were looking at this property level, and we were using that for our observation tool. For the methods, so before the study started, we recruited 6 standardized patients who work at the University of Wisconsin-Madison. We developed 3 scenarios with pre-assigned tasks, and we sent 1 scenario for each patient just to get them more familiar with what they're going to be doing during the usability testing day and make it easier for them. And as I said, we had this observational tool developed, so as a checklist to see the problems that arise during the usability testing. For For the day of the usability testing, the patients were asked to complete patient talk using these pre-assigned tasks, and we asked them to do think aloud method just to hear their thought process. And a researcher sat next to each patient to take notes. It was video recorded, and after everyone was done, we had a debriefing session to get more feedback and reaction, and ask them for suggestions. For the analysis, we conducted a rapid qualitative analysis for the note, the videotapes, and the patient's debriefs. For the findings, so we had several interesting findings. For the logical user interface, patients had no problem navigating between screens. The PRO questions were completed quickly compared to other sections of the app, but the patients reported a difficulty correcting the correct medication when they want to update their medication profile. There was difficulty, choosing the appropriate condition, and also some of the instructions were not read, or patient did not pay attention to some of the instructions of the screens. The hint bubbles were also dismissed. For the graphical user interface, there were reports about some small fonts in the headers, some crowded screens. There were verbiage that were not familiar or clear to patients. And for the efficiency, it took them about 30 minutes to complete the whole talk. For the debriefing sessions, patients shared that they found it helpful in terms of updating their medication profile in the pharmacy, but they have concerns about several things. So they said, we're not sure if caregivers can really complete all the PROs on behalf of the patient accurately. There were concerns about some sensitive questions, and there were issues of social desirability, especially that the pharmacist would know the name of the patient who was sending that kind of information. So for the study implication, we found out that the visual display is very, very important, because if the instructions are not read by the patient, then there might be some questions about the accuracy of the information that they are provided. And also it affects the patient's engagement and their interest in the app. We use the patient's feedback in order to refine the tool, in order to address these kind of problems that have arisen. And also the findings would be used to inform the next steps. So we're going to be updating the type of interview questions that we are going to be asking, the things that we are going to look out for in the observation, and setting the right expectations for patients, because it's going to take 30 minutes. They need to know ahead of time that you have to be prepared for 30 minutes at the pharmacy to complete this app. So it's going to help us, to set the right expectations. And I'm going to conclude my presentation with this quote by Jason Emanuel. By solving our own most difficult problems, we're potentially creating immense value for everyone else. So it's really very important to address these problems right at the beginning before we share this out with people, just to make it a better experience for everyone else. Thank you.
So the 30-minute time period you mentioned was for completing the research task, or was it actually kind of a good estimator of how long a patient might actually use it when they're in the pharmacy?
Yeah, thank you for the question. So we measured the time that each patient took from the beginning of the app until the end, and we averaged that time. We know it's a very small sample size, 6 patients, but the average was 30 minutes. Some took more than that, but that was the average. So we just expected it, the scenario was for a patient who had at least one concern, and they had to update at least one medication. It might take longer if you had more than one medication.
So it was really simulating how some people would really use the patient talk device.
Yeah, that's
Excellent.
what we try to do.
Awesome. Yeah, thank you.
That was a great presentation. Thank you. Can you tell us what your involvement in the next steps of this project are? I'm assuming this is your dissertation.
So I'm building my dissertation on this.
Okay. Can you
Very
share?
big project.
Okay.
Yeah, thank you for that question. So my dissertation is going to be about looking at the 2 things: intention by patient to use this app in the future, because we really want the patient to use it more than once. It's going to be every month. And also we wanna, because an implementation study, you want it to be scaled, you want it to be sustained in the field. So we wanna see if they have intention to use it again. And also I'm looking at the communication piece because that's my area of interest, are the patients, after they use it, are they gonna be like highly participating in communication with pharmacists, are they gonna be sharing more concerns? Will they have more trust because they feel that the pharmacist is really giving them a better counseling experience? So these things I'm gonna be looking at as part of my research.
Thank you.
Okay, thank you all.
Next one is, I think, Daniel. You just hit next.
Thanks. Okay, so presented some work that one of my interns did, similar to Hattie, last summer. So the project was the identification and management of drug-related problems in the ED and narrative review. So it's quite a large distribution that took us part of a 3-month project. So just by means of background and introduction, so drug-related problems, DRPs, actually or potentially interfere with the desired health outcomes. And they include ADRs, medication errors, but also other things, adverse events, etc. It's kind of a global overall term. And when we talk about DRPs, I'm not talking about illicit substances per se, we're talking about those that are part of kind of regulated normal practice prescribed medicines. And globally, 10 to 28% of ED visits are due to DRPs. And in England, that would be potentially up to 5 million visits per annum for hospitals, ED. And of those, up to nearly 90% of those DRPs are considered preventable. And in the UK, we know that ADRs alone, adverse drug reactions alone, which is just one type of DRP, are responsible for 2% of all hospital bed days. And they cost nearly £1 billion per annum. So that's just one type of DRP, ADRs. So we know that DRPs place a huge high burden on EDs, but how do we actually identify and manage them? And it's funny because we don't really, it seems we don't, and we should, as you'll find in a second. So the aim of the review is to investigate how community DRPs are identified and managed in the ED. And by community, I'm just trying to place focus on those that originate outside of the hospital setting, so in primary care per se. So what Tanisha did, she searched 8 databases for literature about DRP identification and management. The search terms used were identification and management, drug-related problems, and emergency department, plus countless synonyms. And we didn't limit by field base, location, etc. And this was to gain kind of as much exploratory perspective as possible. We knew from some early searches there probably wasn't much, if anything, out there. So Tanisha then used title and abstract screening to identify relevant articles as per publications, as per the inclusion and exclusion criteria, which again were purposely broad for the reasons previously given. Inclusion criteria, basically literature which concerns DRPs in ED. Exclusion criteria, things that concern DRPs that were outside of ED. So maybe pharmacists working in community pharmacy and DRP related. So 9,000 just over search results, just over 1,000 potentially relevant, she found from title and abstract screening. Once duplicates were removed, 406 underwent a full text review, and 112 met the review inclusion criteria. But actually, as I alluded to before, only one tested ED-initiated DRP intervention was found, and that was the only one that specifically started at the front door. And this is from a hospital in Spain. It was the ED Pharmaceutical Care Programme, published in 2018. And that was specific to heart failure and COPD patients, so quite a focused, nuanced patient population. And what they did was they compared control and intervention groups. Both had 59 patients. Control group, they had standard care, so they just had their prescriptions written in the ED reviewed. Intervention group, the pharmacists were far more involved throughout. So they took the drug history, reconciled their medicines, so they looked at whether what's prescribed in the ED matched their community records, and reviewed new prescriptions as per baseline standard care, but also had input at discharge and later on in the patient's journey if they were admitted to hospital after ED. And what did they find from that one intervention? Well, in terms of impact on outcomes, so they found 43 potential DRPs in that intervention group, but there was no data for baseline, which made it not very helpful, but they did provide comparative data for drug negative outcomes. And those are the potential kind of outcome due to a DRP. So they compared the two groups for these, lots of them. One example would be poor serum potassium control in those with heart failure. And they compared them for both intervention and control groups retrospectively. Control group, they found 85 DNOs, so 1.44 per patient. Intervention group, they found 56, which was 0.95 per patient. So there was a statistically significant decrease between control and intervention groups. There were other interventions, quite a few. So they were generally, though, limited to identification of DRPs which originated in the ED. So there's a lot of studies of that kind of chart review later on in the patient's journey, or at least it was suggested so from the paper. It's hard to differentiate in what's out there whether those DRPs originated outside prior to ED or actually during ED. That's not captured, and nor was it considered perhaps at the time of those studies. And also, does it even matter? Perhaps. And other studies started after ED, so once patients were admitted to, say, an acute medical unit, etc. But some other themes that were kind of emerged from all this literature is that DRPs are actually difficult to identify for clinicians. So, say for example, diarrhea. A patient presents with diarrhea, severe diarrhea, could be due to organic disease, viral gastroenteritis, could be due to a medicine, a diuretic started, etc. It's quite difficult. Obviously, we have tests, investigations, etc., and it's broader than that, but it can be very challenging for them. The role of history taking was mentioned quite a lot, particularly about focusing on questioning around herbal medicines due to drug reactions, etc. The role of pharmacists came through from some papers and focused on their ability to take drug histories compared to, say, medics or other staff. And severity scoring systems for DRPs were mentioned. Those concern DRPs after identification, so grading systems. We have the ABCD system in the UK for types of ADR. And then risk factors was a big theme that emerged, a main theme. And this was around patient characteristics, so whether those of certain ages were more likely to suffer a DRP, or maybe men versus women. Actually, for both of those, the evidence was contrary on both. And then also about patient status. So if they'd had a DRP in the past, or they've got renal hepatic impairment, etc., those were risk factors to increase likelihood of a DRP. And your typical groups associated with DRPs, unexpectedly, were NSAIDs, anticonvulsants, opioids, amongst others. So, as I said, there isn't much out there, quite clearly, from that. But just thinking about some discussion points, we know that DRPs cause nearly a third of ED visits, yet we only found that one intervention, that includes identifying them from the front door, or near to. Even that wasn't very clear from the paper, but was much clearer than others. The intervention, that one, did reduce negative outcomes, so those drug negative outcomes from DRPs, but was limited to a specific patient cohort, so those with heart failure and COPD. And why is this all important? I only mentioned this earlier on in the first or second slide, but actually it's important to identify and manage DRPs at the front door to ensure patients who turn up with them are cared for in the right place. So whether that's in the ED, it might be by a community pharmacist, by a primary care physician, by the right practitioner, so one in those settings perhaps, and also at the right time. So a patient, a good example I like to give on this subject, a patient presents with a sore throat, could be due to carbimazole, the antithyroid drug. That's called agranulocytosis, presents as sore throat in patients as one symptom, but equally could just be viral. If that carbimazole involvement is not noticed until the patient's been in hospital for 3 days, that itself could cause negative outcomes, patient experience, costs, etc., etc. So that was the review Tanisha did, and this is kind of what it's led on to, thinking bigger picture. So we started a study called DRP Edit. So we're modifying the NHS triage system used across the UK to help nurses at the front door identify suspected DRPs as soon as they arrive. And then off the back of that, develop care pathways to forward patients with suspected DRPs to a suitable clinician, whether it's a pharmacist, A&E consultant, nurse, etc. And then also, you've got patients with a DRP forwarded into the ED to pharmacists. Actually, pharmacists have got lots of other things to do in the ED as well. So how do they know who's best to care for? Who should they prioritise? So we're developing a prioritization tech list, and that's just going through for various grant bids at the moment. And then hopefully in future, building on this, so we know who has a suspected DRP or an actual DRP. We then know who the pharmacists prioritize, and actually can we evaluate the impact of that pharmacist input on the quality of care experienced by those patients. So it's kind of a journey we're going on currently, but this literature review kind of just underpins and confirms some things we suspected. So that's all I wanted to focus on and go through. This is the next presentation, sorry. Are there any questions? Yes.
A comment and then a question, and I'm sorry if the comment sounds strange, but okay. Have you, in your search in the literature, besides DRP, drug-related problems, did you also look at medication-related problems and drug therapy problems? Because those are the other two terms that are used a lot in the literature. DRPs was first, and then those evolved from it.
Yeah, so obviously the first search results from earlier searches, then we looked at keywords and put those back into the search strategy, etc. So yeah, the list of terms was huge. Yeah.
Oh, okay, good. Okay, so that's two questions, because that was my comment, turned into a question. So, no, that was my question. The other one, the comment, sorry, I need more caffeine. No, I just wanted to mention that there is an individual named Neil McKinnon, and he did his work at the University of Florida with Doug Kepler back in the late 90s. They worked on 63 different medication-related indicators that were processes of care that, if they were not done adequately, could result in a drug-related problem. And they found, and they went through a Delphi panel and everything just to get the ones that were the most relevant. And the same drug categories turned up that you were just mentioning. I just wanted to, if you ever wanted to look him up, I don't know that if he, I'm not recall how much he published from it, but they eventually validated it within a health insurance database, just to show that organization how prevalent it was, and it was very prevalent. So it wasn't an ED, but still, it was just interesting to see that they that was one of their indicators.
Okay.
They had many of them, but I just wanted to mention that to you in case that was of interest.
Yeah, no, so for that first next study there, we're doing a systematic review to look at which DRPs lead to ED visits, so then we can incorporate questions to find those into the triage system.
Right.
So yeah, so that'll probably come up in my systematic review, I suspect. Thanks. Yes.
I was wondering if you have any idea of why is there so few intervention studies on this? Why do you think?
A lot of the intervention studies, as I mentioned, weren't about the front door, they were about later on. Even conceptualizing that's quite difficult because EDs globally differ, pathways differ. But just top level, there was lots about kind of chart review. Once patients have been in ED, they've had their chart written by the physician. There's not much about the front door. I don't know why, to be honest.
Is it hard to get the information? I mean, they're in an acute situation, they're not there, so maybe it takes a few days before you have a full medication.
Yeah, and a lot of the study designs are kind of after the event almost as well. But yeah, there's just not much out there. It's quite a challenging topic to study. And also, maybe it was just not, maybe it was not the focus of priority of the research. Maybe it just hadn't been considered that much. There are studies from kind of early 2000s, late 90s in the UK looking at patients who come to the ED, what % of them are due to a DRP, but they didn't really go beyond that and look at actually what can we do now to find them and get them out of ED by solving that almost.
And the one study you did find, how would you characterize what we call the intervention? Is it just simple triage, or what would you say describes the intervention?
Pharmacist,
So front door, pharmacist was there.
it said from the point of patient arrival at ED, but didn't really go on beyond that. So it was probably point from, I don't know for sure, but it was probably point from as soon as they were triaged, I suspect, or admitted into majors. They didn't clarify that in the paper.
So they didn't well describe what
No, it wasn't.
exactly the pharmacist was doing.
Yeah, so but it just showed lots more pharmacist input. Yeah, that was pretty much the intervention. Right. Any more questions? No? We done? Time was.
And there's another question.
Oh, you have one more minute?
Yeah.
Could you just tell us a little bit about the triage system and what it is you think that you're modifying or
Yeah.
what you're anticipating modifying?
Yep, so in the UK, it's called the Manchester Triage System, used in every emergency department. Codes patients, basically a triage nurse puts symptoms into the system. So patient presents with various symptoms, put this into the system, comes up with a likely diagnosis, categorizes that based on measures 1 to 5, 5 being most severe, they're quite sick, 1 being they probably shouldn't be here. So those flowcharts, there's about 54 of them based on symptoms. We're going to hopefully modify those to put in questions about drugs. Doesn't ask, mentions drugs 4 times in 56 charts. It's very superficial. Even though we know nearly 30% of patients have one. 30% of patients have one who arrive, only 5% of patients at ED go because of. So a lot go, maybe for a fracture, but actually also have a DLP, but we don't know, don't look for it. So yeah. Good.
Good.
Hi, everyone. I'm not sure, is Basil like seeing us or anything, or are they sleeping?
Oh, for our orals, we just get videotape.
Okay,
Yeah,
Yeah.
so if you want to, can you stay a little bit more behind the podium because the
okay, that's
capturing you. Thank you.
okay.
We're ready.
So I'm Asma Ali. I'm a first year postdoctoral at the University of Wisconsin-Madison. Today I'll be talking about a mixed stakeholder meeting to inform research with Muslims diagnosed with type 2 diabetes. So just to give you an overview, this project or this presentation is just like a small part of a bigger project in which we have 3 main components, and I'm not sure why is this looking like that. So it's not supposed to be like that. The 3 components of this is, the first one is to build a partnership with the Muslim community, and that includes a primary care clinic, which serves Muslim patients and other patients as well, and also a community pharmacy, which is an independent pharmacy that has about 31 branches around the Milwaukee area in Wisconsin. And the second part is to conduct stakeholder advisory group meetings, and that's to inform the third part, which is that qualitative research in order to explore factors related to diabetes self-management behavior and medication use in Muslim patients who are diagnosed with type 2 diabetes. So the plan for our stakeholder advisory group meetings over a 1-year period is to conduct 3 meetings. Each has different purpose, and for 90 minutes and virtually. So our plan also was like for the stakeholder advisory group members is to have a mixed group of both clinicians and patients. And within the clinicians, a wide variety of clinicians include pharmacists, physicians, physician assistants who provide services to Muslim patients. And in terms of patients, we wanted to include adults who speak English when diagnosed for type 2 diabetes for more than 6 months and take oral medications. Preferably from diverse racial ethnic backgrounds, and of course we want them to speak English for this stakeholder advisory group meeting. And I'm saying focusing on English because in the qualitative study we're including 6 languages within that. So now you get to meet our mixed group of patients and clinicians. Within the patients we included, we had both male and female. We had Arab, African, North African, African American, and also within the patient group, we had a refugee coordinator who was a representative of the Rohingya community. Within the clinicians, we had also Arab, white, and Asian clinicians who were in the group. So it was really important for us to include this mixed group and diverse group because that would provide us with a representation of the Muslim community that's living in this area. So this slide provides a representation of the process of conducting the stakeholder advisory group meeting. We started, of course, with the preparation, then I'm gonna talk about the meeting. So we said it was 90 minutes. Within the first 30 minutes of the meeting, we devoted that time to collaborate with the community members, and also to really create the ground rules for everyone who's in the meeting, because we have a mixed group of patients and clinicians. We wanted to make that space a comfort space for everyone to share what they think is important to share within this space. Then 30 minutes into the meeting, we split into two groups. The first group was a clinicians group, and the second group is for patients. And within that, we went through three main activities. The first activity was to really refine the interview questions that we're gonna ask in the qualitative study. And the second activity is to provide us with more information and help, like in terms of improving the recruitment strategy. And the third one is to provide us with more information about challenges that we might face by including interpreters in the interview. So this was an activity that we conducted in the first 30 minutes. And we wanted to make it, as I said, a comfortable space for everyone. And the main goal is to build rapport within that. So within that, we used something that you might find interesting. We used a sticky, kind of like sticky notes. It's called a Padlet software online, because we were doing this also virtually. And we wanted also to do it anonymously, so that people do not know who wrote what, so that we make it a safe space and comfort space for everyone. And you can see like some really interesting and nice comments that we had here. When people help them to feel comfortable in speaking up in the group, is that when people feel that they belong and they're being listened to. Also, another person shared that when we respect each other and appreciate our differences. So we discussed this with the group, and also we made sure that we're gonna include this in our next meetings as well within the ground rules. I'm sorry, I'm not sure why this is looking like that. So this is for the first activity within the second half of the meeting that we had. And it was, since we had about 40 questions within the interview questions, and within these 40 questions, we had them under 8 domains. So we wanted to make the activity easy for everyone in the group. And so what we ended up doing is that we use also another software online called Mentimeter to help us really rank. First, like we had each group rank 4 of these domains according to the question, how challenging the topic is to you when managing diabetes. And one as the most challenging, 4 is the least challenging. So that like when we went to each group, after that, we got this ranking here. So in the patients group, for example, they ranked participating in healthy behaviors. This is one of the domains as the most challenging for them. And we will talk about these healthy behaviors. So this is mainly within the qualitative study. So we went through the questions under this domain first, question by question, asking the patients, how important is this question to be answered by participants in this qualitative study? And asking them as well, like, do you see that this question is understandable, or do we need to change the wording? So, this is not supposed to be okay. Regarding the outcome that we got from this study is that working with the community, this really reframed the project. We were looking at it from one lens, but we ended up looking at it from the members' viewpoint. So they really were smarter than us. They were a step ahead of us, thinking outside the box. They were like, not only you came to learn from us, we're also here to learn from you. So they wanted to learn more how to serve the community and to help the community throughout the diabetes journey that they have. But also, we did not make the questions shorter. They were like, both the groups independently brought up the topic of Ramadan, the month of fasting, and diabetes management. They were like, where are the questions about that? Like, how are we gonna help the community? So we ended up adding and creating a new domain about Ramadan and diabetes management. And this by itself, like we learned a lot that like we go to the community, we want to learn from them, but they also need help like with that. So Is this the next? Okay. So this was a great experience. This was my first time facilitating a stakeholder advisory group meeting. I'm glad we were able to develop an identity and mutual trust with the community. And also they helped us as well in obtaining recommendations regarding recruitment, like using social media platform like WhatsApp groups, which is common in the community, to increase number of participants. And also one of the interesting recommendations is using for interpretation services is to use gender concordant and in-person interpretation services, so that like females feel more comfortable when they have a female interpreter in the room of sharing their opinions. So here, just like some lessons that I learned, that this was a co-learning experience for both of us. Also, like throughout this process, it was very important to listen and learn from the community and accommodate like what they want and their needs. So I'm gonna also, these are like some of the challenges and strengths that we had. As I say, it was really important to have the diversity that we had in the meeting. And thank you for listening to me. I would not acknowledge Dr. Betty Tuning and the advisory members and our partners. So this is part also of a small grant that is funding this project as well. And thank you. Actually, the pediatrics room, it's a new room in the Muslim Community and Health Center. Questions? Yes.
Thank you for a very nice presentation. I was wondering if when it comes to recruitment, I know that some of my Norwegian colleagues were, they recruited through the mosque.
Yeah.
Did anyone suggest that?
Yeah, they did suggest that actually, because like also we, like last week, we printed the material, like the advertisement material. And as you know, like this weekend was like the big holiday for us this last weekend. And yeah, they suggested that especially through the Rohingya community, because they have a very active leader over there who the community trusts, so that like when they present something for them, they can actually like get them recruited for the study.
I think that worked really well. The other question or a comment that I've heard from some, and it may not be as relevant because you have larger communities here, but in Norway, translator, one issue was that the community was very small. So when it came to talking about personal issues, it was hard to find a translator that was sort of not part of the community, and they were resistant to talking about personal issues in front of someone who they knew talked to others in there.
Yeah. So that's a really good comment, because like what we're trying to do here also, like that was also one of our questions, like within the community, the advisory group. We were like, would that make any issues having people from the community? They were not, no, that would not like have any issues having people from the community. But also we have other avenues through the university. They do have interpretation services that could also be like used other than like people from outside the community. Thank you.
I'm curious about when you talked to them about extending the survey because of the time of fasting during Ramadan. And, you know, if you live in Madison, Ramadan has been falling in the summer where the sun stays up really, it's really a challenge for,
Yeah, it is.
for that. Did they come up with specific questions for you to add, or was it more, here are the topics, you come up with the questions?
Yeah, so the clinicians, they came up like with some questions. They were like, we want to know from the community, how do they handle this? How do we approach them in terms of fasting? Like,
Because they don't know?
so that's
Or-
the,
Okay.
yeah, because they want to learn more like from the community, because also like I don't think that everyone in the community goes to this pharmacy or to this clinic. So
Sure.
like that give us a chance like for a broader audience.
And then the patients themselves as stakeholders, did they suggest specific questions?
Yeah,
Okay.
yeah, especially the refugee coordinator, like he was like, how do we deal with that like within the Rohingya community? Like he was really interested like to learn more about that. Yes.
So Asma, would you share with this group the activity you assist with, and I believe in the communications course, so our student pharmacists learn how to assist patients during Ramadan in their medicine use?
So right now,
Yeah, because it's a required activity. They do this. I'm the timekeeper. We got 2 minutes. 2 minutes.
so I have Dr. Betty Tuning, and Ponyan also was within that group, like helping within this lab. So I'm a newbie, like I know like Dr. Betty Tuning and Ponyan have been there.
Yeah.
So within this, the idea was like to one of the labs for the communication class is to really expose the pharmacy students into to feel more comfortable approaching people from different religions about like aspects that they might not like be comfortable with otherwise. So one of the topic was about fasting, whether it's like with the Muslim or with the Jews or with other religions. So what happened is like instead of having a class or a lecture, we had a panel, and within the panel, the students asked different questions before the panel. So we prepared a small presentation, and then like afterwards, also the students. So we answered these questions through the panel, and after that, students, if they had any other questions, also they asked them like within the panel. That was like a really great experience for us and for the students, because they're like very simple things that like me as a Muslim, I know. So other people might feel like shy asking these questions. So opening the space for them and having this safe space of asking questions, that there's like no offensive question for me as whether I'm a Muslim or as a pharmacist or whatever. So having that and giving them the opportunity to ask the questions and learn, that was like really important. And then like afterwards within the lab, students would be in different booths where they have to communicate with the standardized patient, and they get recorded for that activity. So they also can look back at this video and like have a feedback like for themselves, or also they share one of the one of the videos with the whole group, and they discuss it with them as well. So this is, I'm just like a small part with this, like all of that like was like Dr. Betty Tuning, Ponyan, and Dale, so.
That specific activity is so unique to that every student gets that experience. So thank you for sharing that, and your work has impacted that.
Thank you. Thank you.
So, hi everybody, my name is Mike Watson. I'm from Strathclyde University in Scotland, and I am presenting this study on behalf of the SEPA2 research team. So SEPA2 stands for Sensory Impairment in Pharmaceutical Care. We're funded by the Dunhill Medical Trust. I thought I'd just start with a few statistics. Apologies to those who were in the workshop this morning. Some of this was included in that, but it's literally a whistle-stop tour of some of the statistics that are relevant to older people, sensory impairment, and so on. So we have globally what's been labelled the longevity revolution. So we have growing numbers of people aged 65 and over, and that applies to all the regions across the globe. And this is leading to, oh, we have missing, never mind. This is leading to higher or longer life expectancy. And with longer life expectancy, whilst it's a good thing if you have healthy life expectancy, but with older age comes ill health. And this is a figure from a study published in The Lancet 10 years ago, believe it or not, which is a really elegant way of looking at the aging process and the number of comorbidities that people experience as they age. So highlighted here is for people aged 70 to 74, 30% of them will have 3 comorbidities or more. The important thing here to note is that the the comorbidities that were explored in this study or documented in this study do not include sensory impairment. And the sensory impairment I'm interested in for this study is visual and or hearing impairment. So if you add in those comorbidities to this, there's it's an even greater burden on the individual. So looking globally at stats for these types of sensory impairment, so we have just over 2 billion people who have some form of visual impairment at the moment, and the majority of them are aged 50 years and over. In terms of hearing impairment globally, 1 in 5 people on this planet have some form of hearing loss or impairment, which I think is a phenomenal number. For those people, a substantial proportion of them have disabling hearing loss. And again, these statistics, there's only going to become more and more prevalent as our communities, our populations age. The SEPA2 study focused primarily in Scotland, but we don't have as extensive Scotland-specific data, so I'm presenting for the UK. Just to illustrate the numbers of people that we're talking about. So 1 in 5 people currently are at age 65 years and over, and this is going to increase to 1 in 4 in the not too distant future. The fact at the bottom of the slide there is also very important, I think, because many people aged 65 years and older live on their own. A lot of people assume everybody's got somebody in the household or somebody coming into the household who provides support or care. That is not always the case. In particular, for the sensory loss in statistics for the UK population, we're looking at 15 million hearing, over 2 or just under 3 million with visual impairment, and it's increasing year by year. So a few years ago, we undertook the SEPA1 study, which was more of an exploratory, a fact-finding study. We kind of went broad and shallow to find out what's been happening, what's done. We undertook some interviews with older people with sensory impairment. We did some work with community pharmacists to find out from their perspective, their training, the pharmaceutical care that they currently deliver for older people with sensory impairment. So all of that is published. What the bottom line of that program of work was, there's actually not very much activity or exploration or solutions that have been identified from empirical research on this topic. Surprising given the numbers of people involved. So we look at this from SEPA2 perspective. We've been thinking about the patient journey or the medicine journey from the point of the healthcare consultation with whoever the healthcare practitioner is, whoever is the prescriber. So in the UK, we've got lots of different types of professionals who can prescribe medicines, from doctors, pharmacists, nurses. We've got quite a number of independent prescribers. But we wanted to look at the whole journey and see what the challenges were. And for SEPA2, rather than going broad and shallow, we wanted to go narrow and deep. And these, the elements of the journey that we particularly focused on were from the point of view, from the starting point of ordering onwards for the SEPA2 study. So we wanted to conduct what we called a day in the life. We wanted to explore a day in the life of older people, so people who are aged 65 and over who had either visual, hearing, or dual impairment. And this was all fantastic and hunky-dory because we got the funding in February 2020. And what we were going to do prior to the global pandemic was we were going to recruit our participants. And we were going to get them to wear body cams and just to show us throughout the day where their medicines were, how they interacted with them, what they did with them, what they didn't do with them. It was going to be a mixed method study. It turned into a mixed method study, but not the one that we anticipated doing. So basically, ethics said you can't have any direct contact with these participants, and that was completely understandable. So what we wanted to do was just explore what did they do and what were their experiences of their medicines. So we basically had to negotiate with the participants to say, okay, what data do you want to collect, and in what format can you collect it for us? And we were completely open to what they could do. So they undertook, they made videos, they took photographs, they made voice recordings, diary notes, and some did a whole combination of things. And it was really inspiring to see the kind of data and the extent of data that people collected and submitted to us. What we also did was we undertook interviews with the participants. What we had also wanted to do was undertake interviews with the participants' nominated community pharmacists and GP to kind of triangulate who knows what about the individual and how do you compensate, how do you accommodate your prescribing or your supply of medicine for this individual and their needs. I think we only were able to interview one GP, and I'm not sure, I can't remember about the pharmacists, but quite a number of the participants couldn't actually, they had very little, if any, direct contact with the community pharmacist. It was all done by remote ordering, and that was pre-COVID as well. So we didn't get the full data for everyone that we had wanted. So we wanted the journey of 15 people. We got 40. So we wanted 5 in each of the sensory impairment groups. And these are some of the characteristics associated with those individuals. So you can see the age ranges were from 65 to 89. 5 of them lived alone. And the number of medicines, we had a threshold, they had to use 4 or more medicines in order to be eligible to participate. So the people here, they use between 5 and 21, which is unbelievable. So the kind of overarching findings that we derived from the data that they provided was that these individuals have developed incredibly individualized strategies, coping mechanisms, very complex for arranging, storing, administering their medicines. And these strategies they've customized to their home environment. All of these were community dwelling, independent, without adults. They've all been customized to their home environments, and also their routines have been customized to their medicine requirements. They've used a whole range of different approaches to store their medicines. Some of them, to me as a pharmacist, I'm just traumatized by, and you'll see what I mean in a minute. But the thing is, it works for them. It works for them, and that's what matters. There was a range of different types of assistive technologies that they use, from really low tech, magnifying glasses and so on, to smartphone apps as well. So those were the kind of most core findings. These are just a few images. So the picture on the left, my right, your left, yeah, with the gentleman's hand, you can see he's got this wooden box. So every time he gets his medicine supply, he takes them out of the original packs and he puts all the strips in this box. And this is how he sorts them. And different people use different strategies for storage. And also the image here, this lady's a bit forgetful, so she's worked out her own strategy for how she remembers if she's taking her medicines or not. I'm going to finish very briefly with a short case study of one of the individuals who participated, just to give you a flavour of their lives and how they interact with their medicines. So this lady, she was wonderful, 71 years old. She lives on a really remote Scottish island. She lives on her own. She uses a mobility scooter. She has dual impairment, so quite severe, but if you look at her and you hear her, you would not know that she has either of these impairments. She undertook extensive videos to demonstrate how she interacts with her medicines. And she did this by waiting for her daughter to come and visit her last summer. And they set up the video and they did it themselves. So these are her medicines and her medical devices. So a range of formulations, a range of dosing times. I don't want you to do any medication review here. Even though I haven't seen a patient in front of me for quite some time, I'm thinking, I think I could do something to improve what's listed here. I'm not convinced it's all necessary. So that was her. So just to illustrate the complexities and the burden that's on people for just their medicines at least, I wanted to finish with this quote from another of the participants to emphasize the importance of independence. So I'm going to let you read that before I move to the end. So these individuals, these patients are very keen to maintain their independence to the best of their ability. Moving forward, we're finalizing the analysis of the study. We're using all the data that we've collected from SEPA1 and SEPA2. There's different elements. And we're moving on to the next phase where we're going to be co-producing service and product specifications to try and start to develop some solutions to the challenges identified. We're also developing a MOOC for health and social care professionals to increase their understanding and awareness of the needs of older people with sensory impairment in terms of the medicines. And we're also collating a resource that summarizes all the different types of products and technologies that exist in the use for medicine. These are my colleagues with this study, and for more information, you can use any of these details here. Thank you. Have I exceeded my time limit?
No, we got time for 1 or 2 questions.
I was involved with a colleague in a study which they were of children taking photos, and our institutional review board told us we couldn't do that. And I wondered, were your people told not to take pictures of other people? Was there any, just in terms of the parameters of what they could do, did you have any parameters at all?
Yes, so we weren't, if they were going to be out, say in a community pharmacy or practice, they weren't permitted to take photographs there. They weren't permitted to take photographs of other individuals, unless it was somebody in the household that had consented to that. But even then, if they had a carer, like a social services carer or somebody like that, I think we had asked that they didn't take photographs of them either, because we didn't want there to be any pressure put on either person to take or not take photographs. So yeah, there were some ethical considerations.
Yeah, I just think it's a fabulous way to collect a picture. You know, it's just wonderful. It's just wonderful. I'm glad that you found a way to do it.
Yeah,
It's great.
Thank you. Daniel?
Really interesting study and presentation. What were your kind of plans for what to do with all the data in the long run? So you're going to kind of, sorry if I missed, you've mentioned it, but is it kind of to develop interventions to help patients live better with the medicines?
Yes, so developing, we're going to be co-producing specifications for services for specific types of sensory impairment and the specific activities in the journey, and also technologies as well. So for example, Dunhill, the funder, have funded a cohort of 4 PhD students that will start in October. And one's going to be based in biomedical engineering, and he is going to develop a device to support people's use of eye drops, because eye drops is a huge challenge for our visually impaired people in general, but it's also for our patients with glaucoma. It can be the difference between them retaining some sight and losing it completely. They need to be able to use their eye drops effectively, and they can't at the moment. And that's due to the bottles, the shapes. It's also due to the grip strength. As we get older, our grip strength declines, and for a whole variety of reasons. And so that's one of that kind of thing that we're trying to take forward.
I had a practical question. When is your MOOC gonna be available?
At the end of this year. That's what I tell the educational strategy team. They keep saying, and where's the data, Max? And I'll say, next week, maybe the week after, but no, that's the plan, because the funding is officially until the end of January, and I want the MOOC launched before we get to the end of the funding, because it's one of our funded outputs.
And will that be on one of the, well, what I view as a standard platform, edX or Coursera or something
We are
else?
using Future Learn.
What is it?
Future Learn. And it will be, although we're targeting health and social care professionals, we are using lay terminology throughout, because we want anyone who is interested in this and for whom it is relevant, we want everybody to be able to access it and understand it. So that's how we're pitching it.
What an outstanding group of presenters this afternoon as well. Airplane a lot more today. It sounded like more airplane noise today. So I apologize for that, and I'm not sure what happened to your slides on those goofy things. But again, a testament to the patient-centeredness that everybody keeps taking in this room. Whether it's the stakeholders, the plan for better ED care and identification and resolution of problems, problem solving, medication use for, I mean, just an incredible just efforts and all that we're doing. So I wanted to switch this over. We're going to take a brief stretch break here and what?
break.
Yes, I think if we can put Betty on the spot and have her help us stretch a little bit, it'll also allow some folks to commiserate on the thing. And I gotta make sure our YouTube sound will generate in this room so we can watch the poster. So give me a second to check that out.
Anybody who would like to participate, this is very, very, very simple. You know, just be a couple of minutes, like, you don't have to, but if you want to, then you come out there and make sure you get a little bit of space. I'm just gonna repeat something that I did at place earlier. You're here and it's almost like you're sitting over your feet, just a little bit, so your legs, your knees will be bent. And I put elevate that. And let's start by just
When I get back.
silently breathing. Put your hands on
A minute.
here.
Yeah.
And then take about 10 breaths. Think about when you're breathing out, when you're breathing in, just take 10 breaths and there, relax. when you taking about 10 breaths and open your eyes. And what we're going to do now, Tai Chi is actually a form of Qigong. Qigong has to do with the movement of energy, they said this morning. And it's a lot about relaxing for energy to move. So now all we're going to do, you can have your hands at your sides if you want, just really relax. We're going to do a move which, if you were going to do one move for the rest of your life, to improve your balance, this would be it. Probably. Maybe there's a whole set. This is, if you can only do one, if you were going to do one, this is it. And all you're going to do is you're just going to balance. You're going to go to your, I guess, your left, and breathe. Maybe breathe in as you go that way, and then breathe out as you come over to your other. And try to be sort of focused on over that foot when I'm doing it. Okay, and then I'm going to come over here. So let's go back and forth, breathing in and out as we go back and forth 10 times. So there's 1,